Okay, we are live.
Sure.
A very good evening to one and all present here, and I welcome you all to another session of the YOSI Journal Club. At the very outset, I would like to begin by introducing the Governing Council, a prolific set of office bearers to lead all young ophthalmologists in India, who are supported by the executive member set, which are 20 executive members spread all around the country and outside as well. Leaving that aside, we come into the subject matter for today, that is the concept of the Journal Club, which was begun by YOSI first in India. And over here, we have a way in which journal articles can be discussed among young ophthalmologists to help understand not only the research methodology, not only the conclusions derived, but also its application in daily clinical practice. So in the format that we follow in the YOSI Journal Club, we define the problem that is out for us. We specify the research question, define the variables and the subject selection. We discuss the appropriate research design that was employed, analyze the data, and interpret the results according to the Mary format, which we will come across. The format of the Journal Club is of great interest because for one long month, a presenter, that is a young ophthalmologist who may be a resident, a fellow, is assigned to a mentor who guides the ophthalmologist or the young researcher throughout the month regarding an article of interest. And on the day of the Journal Club, they are joined by a research expert who breaks down the article, as well as panel members who are experts in that field to break down the advantages, disadvantages, newer aspects of the article out for the audience. So the format followed is the Mary format to break down an article, which stands for method, assignment, assessment, results, interpretation, and the extrapolation, which is a step-by-step approach employed by us to go through the journals. This is the team for the YOSI Journal Club, led by Nupur ma'am. If you are watching this and would like to participate in any YOSI Journal Club in the future, please take a screenshot of this page and send us an email, and we will be glad to have you. The very first session of the YOSI Journal Club was nearly 2 years back, and we had one discussing glaucoma. This was followed by the second session on endophthalmitis, followed by cataract surgery, followed by ocular oncology, followed by pediatric ophthalmology, followed by oculoplasty, which began the second season of the YOSI Journal Club series. This was again followed in the second season with glaucoma, pediatric ophthalmology, retina, and refractive surgery, followed by December, where we ended with cornea. And now we come to the third season of the Journal Club series that began again in March with cornea during the month of March. In the month of April, we had glaucoma. And this brings us to today's Journal Club, which is in the month of May, where we'll be discussing retina. So the research article chosen for today reads, and I quote, imaging biomarkers and clinical factors associated with the rate of progressive inner and outer retinal thinning in patients with diabetic macular edema. This is from the Nature Scientific Reports journal, which has an impact factor of 5.5. Joining us today is our research expert for this evening, Dr. Sharath Hegde sir, who's currently a consultant in retina at the Prasad Nethralaya UDP Karnataka since 2019. Along with that, we have a prolific expert panel. I would just introduce them for a short while now and go into the detailed introductions later. Dr. Aniruddha Agarwal, who's an associate staff physician in medical and surgical retina and uveitis at the Cleveland Clinic in Abu Dhabi. Dr. Dhaivat Shah, who is the joint medical director and the head of the Department of Vitreoretina and Research at the Chaitram Nethralaya in Indore. And Dr. Rohit Modi, who's the director of the Central Clinic and Hospital in Mumbai, all prolific vitreoretinal surgeons by their own standards. The mentor who's been guiding our mentee and our presenter for this entire month is Dr. Shashwanti Mohan, who is a specialist ophthalmologist in vitreoretina at the Medcare Eye Research Center in Dubai, and is also an education and research associate at the Rajan Eye Care Center in Chennai. The speaker and presenter for this evening is Dr. Akash Chaudhary. He received this initial training in Hindura Hospital, Delhi, and is currently a second-year surgical resident at Rama Medical College at Hapur. And my name is Dr. Anujit Paul, and I will be a moderator for this evening. With that, I will not waste any more time, and I will call upon Dr. Akash to please share his screen and we can begin.
I hope the screen is visible to everyone. And without wasting further time, I'll present this article titled Imaging Biomarkers and Clinical Factors Associated with the Rate of Progressive in Patients with Diabetic Macular Edema, which is currently published in the Nature Scientific Reports. The introduction section leads to definition of diabetic macular edema, which is associated with chronic visual loss in diabetic retinopathy and is characterized by a compromise of the inner retinal blood barrier leading to formation of intraretinal cysts, hard exudates, and disorganization of retinal inner layer. OCT is an imaging modality which grants a qualitative and quantitative assessment of structural parameters of the macula with good precision and reproducibility. This is a sample image of the intraretinal cyst as is clearly visible in this OCTD scan. The disorganized retinal inner layer. Diabetic macular edema can manifest with different morphological patterns on OCT, like diffuse macular thickening, cystoid macular edema, and subfoveal neuroretinal detachment. As per existing literature, CME or HND are currently associated with a poorer visual prognosis in DME. Both a smaller and greater foveal thickness are associated with a reduced visual acuity after the resolution of the intraretinal fluid, regardless of the OCT pattern. Regarding relationship between OCT patterns and the rate of retinal thinning in DME. The aim of the study is to provide a longitudinal quantitative analysis of the inner and outer retina in different anatomic phenotypes of patients with early DME followed prospectively for 3 years. The material methods devised in the study were the retrospective cohort study. The study period being 36 months. Study subjects were center-involved DME diagnosed patients who were aged more than 18 years old, with the final study cohort of 50 subjects, having 56 eyes. Chief investigation employed in the study was spectral domain OCT, and the equipment used was the Heidelberg Spectralis Pictariflux OCT. Inclusion criteria and exclusion criteria have been clearly defined in the study, wherein the inclusion criteria had age more than 18 years old, a diagnosis of center-involved diabetic macular edema, history of anti-VEGF injections, history of 3 yearly clinical assessments over a period of 3 years following first confirmation of DME resolution after anti-VEGF initiation. The exclusion criteria involved treatment with macular laser after initiation of anti-VEGF injections, history of vitreoretinal procedure in the study eye, other macular VR or optic nerve pathology, and layer disruption on OCT. Visual acuities were tested with Snellen charts and successively transformed to logMAR values. Diagnosis of center-involved DME were based on clinical and imaging assessment. Subjects which fulfilled inclusion criteria underwent Prorineta anti-VEGF treatment with either of ranibizumab, aflibercept, or bevacizumab, during which switch to intravitreal dexamethasone implant was at treating ophthalmologist's discretion. The baseline visit and follow-up visit were clearly defined in the study, wherein a patient visit wherein first confirmation of DME resolution, which was defined as reformation of the foveal depression with a foveal thickness inferior to 315 microns post anti-VEGF treatment was identified, and follow-up visit was classified as the first visit with OCT confirmation of resolved DME after a follow-up of 3 years. Visits for analysis included only those wherein fluid resolution was characterized to avoid intraretinal fluid from confounding the OCT quantification. First part of the quiz leads to this question: which photoreceptor cells are responsible for color vision in the retina? Are they A, rod cells, B. Cone cells, C. Ganglion cells, or D. Bipolar cells?
So Dr. Priyanka Jain in the chat box has said option number 2. Prakash, can you tell us the answer?
Answer is correct. Photoreceptor cells which are responsible for color vision in retina are the cone cells. Moving ahead with the OCT analysis of this study, the principle deployed was spectral domain OCT and equipment used was Heidelberg Spectralis HRA plus OCT. The testing protocol which was employed included each volumetric scan, which was characterized by a minimum signal strength of 25, composed of 19 horizontal B scans and covering an approximately 5.5 by 4.5 millimeter area, which was centered on the fovea. This is an illustrative image of the machine which was deployed in this study. OCT images were then investigated for the inner and outer retinal thicknesses using built-in software, which uses an algorithm that detects and calculates thickness of the retina inside the different ETDRS grid regions. The ETDRS grid comprises of 9 sectors, which are centered on the fovea and is divided into 3 circles, which were at a distance of 1 millimeter, 3 millimeter, and 6 millimeters from the foveal center. They're divided as central fovea subfield, which is described as the area within the inner 1 millimeter diameter circle, as is previously shown. The inner circle subfield is the area between inner and middle 3 millimeter diameter circles, and the outer circle subfield is the area between the middle and outer 6 millimeter diameter circles. The inner retinal thickness and outer retinal thickness were clearly described in the study, wherein the inner retinal thickness is the area measured between inner margin of the nerve fiber layer and the inner boundary of the outer plexiform layer, whereas outer retinal thickness was measured as the area between inner boundary of the outer plexiform layer and the inner margin of the retinal pigment epithelium. OCT images were first reviewed for eligibility by an expert and certified reader and a junior grader. All OCT B scans were evaluated by 2 readers before calculating the thickness values to correct any decentration or segmentation errors. 2 graders also reviewed OCT images between baseline and follow-up visits in order to define the DME phenotype for each case. Cases with intraretinal areas of reduced reflectivity were categorized as being affected by a diffuse macular thickening. Cases developing cystoid spaces in the 1 millimeter central circle during the 3-year follow-up were graded as being characterized by cystoid macular edema. Subfoveal neuroretinal detachment was characterized by a hyporeflective space below the neuroretina. This is the structural OCT of eye with DME, and we can clearly see that diffuse macular thickening, as is described in the last slide, is the intraretinal area of hyporeflectivity. Cystoid macular edema is characterized by cystoid spaces, and subfoveal neuroretinal detachment is characterized by a hyporeflective space below the neuroretina on OCT scan. Discrepancies between the 2 graders were resolved by consensus or adjudication by a 3rd experienced grader. Next part of the quiz brings to this question, which says, which part of the retina is responsible for the highest visual acuity? Is it A, fovea, B, optic disc, C, macula, or D, peripheral retina?
So from the chat box, Dr. Priyanka Jain has again answered with option number A. Akash, can you tell us the answer?
The answer is correct. Fovea is the part of retina which is responsible for highest visual acuity. Moving ahead with the statistical analysis of this study, Shapiro-Wilks test was performed for all variables. Means and standard deviation were computed for all quantitative variables. Statistical significance of the differences for quantitative variables was assessed using Wilcoxon signed rank test. Contributory factors affecting inner and outer retinal thickness changes were examined using a univariable and a multivariable linear mixed model. Multivariable models were constructed, including the following potential confounding factors like age, gender, and any other parameters in which the p-value was less than 0.1 in a univariable analysis. The statistical package for social sciences version 23.0 was used for statistical analysis, and the chosen level of statistical significance was p less than 0.05. Moving ahead to the results section of this study, 56 eyes from 50 diabetic subjects, which included 29 males, 21 females, met inclusion criteria and were enrolled in this longitudinal study. Mean age at baseline was 61.4 years. The visual acuity was 0.27 logmar at baseline and 0.26 logmar at study visits. Mean number of intravitreal anti-VEGF injections was 4.8 before baseline visit and 8.1 during the follow-up period within baseline and study follow-up visits. The DMA appearance during follow-up was defined by the OCT phenotype, wherein 13 eyes were said to have subfoveal neuroretinal detachment, of which 8 were with concurrent cystoid macular edema. 27 eyes were described as having isolated cystoid macular edema, and 23 eyes were described as having diffuse macular thickening. Irrespective of the OCT phenotype, subfoveal neuroretinal detachment occurrences, the mean occurrence of the subfoveal neuroretinal detachments was 0.39 and of cystoid macular edema was 1.53. Longitudinal changes in inner and outer retinal thicknesses were examined at the baseline and follow-up visits separately for the inner and outer retinal thicknesses. The perifoveal and parafoveal thickness at the follow-up visit for the outer retinal variable was significantly decreased as far as comparison with baseline visit was concerned. However, no such change was observed at the foveal area. The rate of thinning for the perifoveal region in the inner retina was described as minus 2.9 microns per year, and for the outer retina as minus 1.8 microns per year. The parafovea area was appeared to be thinning at a rate of minus 3.5 microns per year for the inner retina and minus 1.3 microns per year for the outer retina. As far as fovea is concerned, the inner retinal area was thinning at a rate of minus 1.5 microns per year and the outer retina at a rate of minus 0.5 microns per year. There were several variables which had significant statistical associations, like the type of diabetes, wherein type 2 was associated with a foveal inner retinal thinning as compared to type 1 diabetes. Higher number of SND recurrences during follow-up was statistically significant faster foveal outer retinal thinning. Type 2 diabetes, higher age, and CME phenotype were seen to be associated with increased parafoveal inner retinal thinning, and gender and diabetic retinopathic states were associated with a statistically significant faster perifoveal inner retinal thinning. Coming to the next part of the quiz, what imaging technique is commonly used to diagnose and monitor diabetic macular edema? Is it A, magnetic resonance imaging, B, ultrasound imaging, C, optical coherence tomography, or D, X-ray imaging?
So once again, Dr. Priyanka Jain has answered with option C. Akash, can you go ahead with the answer?
As is described in the study, the imaging study uses optical coherence tomography. Discussing the study, wherein the DME phenotypes were associated with the rates of inner and outer retinal thinning in patients undergoing anti-VEGF treatment, the number of subfoveal neuroretinal detachment recurrences during the study period was associated with a faster thinning of the outer retina. CME phenotype showed faster rates of parafoveal inner retinal thinning. subjects with vitreomacular disorders and those without resolution of DME after 3 years of follow-up in at least one visit were excluded in terms with the exclusion criteria which has been clearly defined in the study. As specified before, DME may manifest with different morphological patterns on structural OCT. One of the most notable observations from the study was that the number of SND recurrences occurring during the follow-up was associated with a greater outer retinal thinning in the foveal region. The authors speculate that accumulation of subretinal fluid may cause a mechanical damage to photoreceptors, resulting in a longitudinal thinning of the outer retina. Authors confirm that the inner retinal layers progressively reduce in DME eyes, and this reduction does not appear to be influenced by treatment characteristics. In the study cohort, presence of a CME pattern was associated with a greater longitudinal parafoveal inner retinal thinning. Results seem to suggest that presence of large cavities within the retina may cause an irreversible damage to cells located in the inner retina. There are two potential hypotheses which may explain this. The post-receptor functional loss hypothesis, according to this, the neuronal damage may be a consequence of impeded exoplasmic transport secondary to the presence of cysts. As per the mechanical tension hypothesis, mechanical tension to the retina caused by presence of large cysts may lead to a subsequent loss of inner retinal cells. Diabetes variable in this study were also having statistically significant associations, wherein type 2 diabetes was associated with faster inner retinal thinning, type 2 diabetes had a greater inner retinal thinning, and proliferative diabetic retinopathy patients had association of faster perifoveal thinning of the inner and outer retina. Coming to the last question of this quiz, which class of medications is frequently used for the treatment of diabetic macular edema? Are they A, ACE inhibitors, B, beta blockers, C, non-steroidal anti-inflammatory drugs, or D, anti-vascular endothelial growth factor agents?
So once again, Akash, Dr. Priyanka Jain has answered with option number D. So you can tell us the answer.
Pretty active, I must say. D, anti-VEGF agents is the correct answer for treatment of diabetic macular edema. There are a few limitations listed in the study as per the author's perspective. First one being it is prone to selection and ascertainment bias. The included patients were not followed up at regular intervals as the cohort was not part of a large trial, and others included only subjects who had at least 3 yearly retinal visits over a period of 3 years after the first evidence of DME resolution. DME classification was based on subjective grading, and to address this limitation, 2 graders were tasked with classifying DME phenotypes, and the final grading was obtained after open adjudication. Other uncontrolled differences in ocular and systemic features among DME phenotype groups might have affected the retinal measurements. To come to conclusion of this study, the study investigated the association between DME patterns and long-term rate of inner and outer retinal thinning in DME eyes treated with anti-VEGF therapy. The results appear to suggest that clinical characteristics, including DME phenotypes, may affect both the inner and outer retinal thinning. Presence of large cystoid spaces may determine an inner retinal thinning, and development of subfoveal neuroretinal detachment seems to be associated with the longitudinal thinning of the outer retina. These findings may help broaden our knowledge regarding the natural history of diabetic macular edema and evolution of retinal damage in these eyes. Coming to the MARI analysis of the study, the study hypothesis was well defined, sample size was small, the study population included Italian Europeans. There was a well-defined inclusion and exclusion criteria in place, and the study period has been well-defined. The process involved was a retrospective cohort study. Possible confounding variables included differences in ocular and systemic features among DME phenotypes, which could have affected retinal measurements. There are a few characters about diabetes which were unknown, like the duration, the glycemic control status, and NPDR and PDR samples were not quantified. Other systemic comorbidities might have acted as additional confounding. Number of prior anti-VEGF injections was unknown, and history of other drug usage is also unknown. The measurement of outcomes has been tabulated and properly analyzed. Proper methods were undertaken to eliminate bias and limitations as far as possible. The results, as previously described, considering whole cohort of subjects and irrespective of the DME phenotype, the rate of perifoveal, parafoveal, and foveal thinning has been clearly described. The study adds to existing literature in diabetic macular edema prognosis. Imaging biomarkers utilizing spectral domain optical coherence tomography are well described. A well-detailed analysis of the OCT B scans is done with 3-layered attempt to eliminate analytical bias in conjunction with other demographic and systemic factors. A detailed analysis provides quantitative evidence on progressive retinal thinning in patients of DME, particularly center-involved DME. Results cannot be extrapolated for all populations due to lack of respective evidence with respect to other racial cohorts. No separate sample quantification of NPDR and PDR patients was found. There is no information regarding number of anti-VEGF injections, and there are no details regarding intravitreal dexamethasone implant switch during study period. With this, I come to an end of discussing this paper and would like to acknowledge Dr. Anujeet Paul, who was kind enough to invite me for this event, and my mentor, Dr. Sashwanti Mohan, who has also been kind and patient enough to have been taking my doubts, and the whole team who has been continuously providing me with inputs throughout the study discussion. Thank you so much.
Thank you so much, Akash. That was very lucidly presented. A Retina article isn't that easy to present. I'd request you to unshare your screen so that I can share my screen. So without any delay, I would like to move on and I would like to invite our research expert for this evening, Dr. Sharath Hegde. Dr. Sharath Hegde completed his MBBS and MS from JJMMC Davangere, after which he completed his fellowship in vitro retina from the prestigious L.B. Prasad Eye Institute in 2016. He's currently a consultant of retina in the Prasad Nethralaya UDP in Karnataka since 2019, working on artificial intelligence in diabetic retinopathy. He's an active member of many ophthalmological forums and has presented numerous papers and posters in and published in international and national textbooks and journals. With that, Sharath Hegde, sir, I would just invite you to analyze the research paper for this evening.
Thanks, Anujit. And I thank you, the YOSI Journal Club Forum, for giving me this opportunity. I just share my screen.
Sure, sir.
So I'm just trying, can you able to see my screen?
Yes, sir, I can see your screen. Yes, it's in full screen.
So I'm just trying to put my analysis on the statistics of this journal and also touching on the basics of the stats, hoping the most of them are postgraduates who are attending this session. So the research question being imaging biomarkers and clinical factors. I think this is a very relevant question nowadays because diabetic macular edema can develop retinal thinning, and whether the outer or inner retinal thinning, what can be the imaging biomarkers which can help us to look into that. The research question looks very relevant. I'll tell you the conclusion whether how much it is a relevant part of it. So just coming to the basic, this study is a retrospective longitudinal observational study, which can also be told as a cohort study. So mainly in any studies, there can be two types. It can be observational studies or experimental studies, where in the experimental we have RCT and non-RCT studies. But in the observational studies, they are mainly population-based and individual-based. Most commonly, we as students or we as researchers, we worry on individual-based studies. And in that, mainly we see three types: cross-sectional study, case control study, and a cohort study. So cross-sectional study means whenever the study has been done on the fixed time, on the fixed period. For example, you take a systemic blood pressure. If you see the number of the age of the patients who had systemic blood pressure more than 160 at one point of time, at today's date, that time will be like a cross-sectional study. Similarly, cohort study means the same condition in the same patient, which we see over a period of time. For example, if you take a systemic blood pressure today and what it will be there at the next 6 months later or next 1 year later in the same patient, that will become like a cohort study. Case control study is a condition where already the patient had developed heart attack. And now you will see whether the systemic blood pressure is the cause or not. That is the case control study. So this study based on the what they have done, taken the data, it is a retrospective cohort study which has been done. So next, coming to the data collected, they have nicely told that they have taken the data of the patients more than 18 years of old in their EMR sheets, and previous other study trial, they have retrospectively they have taken the data. But I feel from which year to which year the data has been collected also was important, because the treatment style, the treatment protocol, which was there previous 15 years before, now is different. So that may be also one of the confounding factor, or it can become a bias. So I feel they should have mentioned from which year to which year the study data has been collected. And to look into the normality of the study, they used the Shapiro-Wilk test for normality. So just to touch on normality, it can be parametric or non-parametric. So when it follows the Gaussian curve, we say it as parametric data. When if it not follows the data, it was non-parametric. This becomes important because the statistical analysis and the test what we use also will change. Here they have used Shapiro-Wilk test. Usually this test is used for the less than 50 patients. Here it is 56, which we can use this study. There are other studies like Z test or QQ test and P test. The only thing is in this study they are told they have used this variable, this study, Shapiro-Wilk test, but they are not mentioned what's the value of it. So seeing on the what test they have used for the statistical significance to see, they have used Wilcoxon sign rank test. So we will assume the what they got the result of the previous test was a non-parametric study data. So they have used the appropriate test here, Wilcoxon sign rank test, where you can see this is paired data, where we are seeing what is there at the initial visit, and the same data will be taken at the last visit in the same patient. So they used the proper test, which is Wilcoxon sign rank test. The other important what they used is the univariable and multivariable linear mixed model, and they used the p-value which was less than 0.1 in the univariate model for the multivariate thing. But they are not told which multivariable test they have used. Commonly we use ANOVA or regression analysis, but they are not mentioned which it is. Coming to the rate of thinning, they have mentioned clearly that every year the rate of thinning was there. But whenever the patient comes, they are told in a year, one visit should be there. If the patient has come in the starting of the year in January, and next the patient has come in the mid-September or October in the next year, it becomes a very long period which they have not mentioned. Ideally, it will be better if they come at the same time, the same year. That time the rate of thinning may be helpful. This statistical data looks appropriate, where they showed nicely the p-value of less than 0.01 in the both things. And even in the foveal area, the p-value is appropriate and is significant. This is the table what he has shown, where univariable and multivariable analysis, and they are nicely showed whether the age is correctly matched or not, and gender is matched or not, and what other variables are significant. And I feel this has the analysis has been done nicely. So coming to the conclusion, the imaging biomarkers and the clinical factors, the research question looks appropriate. Only thing is they have taken only the OCT imaging biomarkers, has outer retinal thinning and inner retinal thinning. If they have added multiple factors which can cause, was also important. And the clinical factors, they have taken only age and gender. I feel the blood pressure and other anemia and other risk factors also would have been helped us further to explain about it. Thank you.
Thank you so much, sir. Thank you for lucidly breaking down the statistical aspects. I think as young ophthalmologists and residents, we tend to skip this aspect when we come to reading the paper and just jump from the methods right till the results and the discussion. So it's good that we are revising this during these sessions once again. With that, I'll just share my screen once again. And we move on to our expert panel for this evening. And right in the beginning, I'd like to invite Dr. Rohit Modi, sir. Dr. Rohit Modi completed his fellowship in Retina and Uvea and has some special interest in biostatistics. He's currently the director of the Centra Clinic and Hospital in Mumbai. And I would invite Rohit, sir, to share his thoughts on the positive aspects of this research paper.
Thanks, Anujit, for the opportunity to be a part of this wonderful YOSI Journal Club. And at the outset, I feel it's a very interesting approach the authors have taken, to follow up the OCT in terms of looking at the inner and the outer retinal thickness. And well, it definitely gives a new approach to determine, in which phenotype what part of the retina we are looking at thinning out, and it broadens our knowledge about the prognosis part. Because if I talk about solo private practice in which what I am doing, it is very, very important to understand how the visual acuity is going to improve, because if the visual acuity improves, then obviously the follow-up is better, and it becomes easier for us, because a lot of patients are paying out of pocket. And again, it becomes very challenging to explain to these patients if with repeated injections we're just able to kind of maintain the vision, or probably some of the patients do have a slight drop in vision. Obviously, it would have been great that if the authors would have considered the systemic control also, which goes in a long way in helping the anti-VEGFs to respond better. So I believe in those aspects, the authors have done a good job.
Thank you so much, sir. Always bringing in clinical practice into the discussion, which is so important currently. With that, I'd like to invite Dr. Aniruddha Agarwal, sir. Dr. Aniruddha Agarwal is currently working as an associate staff physician in medical and surgical retina and uveitis at the Cleveland Clinic in Abu Dhabi. He was previously a faculty member as an assistant professor at PGIMER Chandigarh and has completed his clinical research fellowship at Stanley Truson Eye Institute in Omaha, Nebraska in the United States, and a surgical vitreoretinal fellowship from PGIMER in 2016. He has also received the Kataria Memorial Gold Medal from the Prime Minister in India in 2014 and has authored numerous textbook and book chapters and publications. With that, Dr. Aniruddha, sir, I'd like to invite you, sir. I'm not sure if sir is having some connection problems. In case he is, I'll just move on to the next panel member and I'll come back to Aniruddha, sir. I think he's having some connection problems. Right, so we'll come back to Aniruddha, sir. I'll move on to the next panel member, Dr. Dhaivat Shah, sir. Dr. Dhaivat Shah is an Indian and DHA board certified ophthalmologist and vitreoretinal surgeon who completed his long-term fellowship in vitreoretina from the Shankar Nethralaya in Chennai. He's currently the Joint Medical Director and the head of the Department of Vitreoretina Research and Academics at Choitram Nethralaya in Indore, which is one of the largest institutes in central India. He has over 52 peer-reviewed national and international publications and has performed live vitreoretinal surgery at numerous events. He has multiple research projects under his belt with collaborations with organizations such as Sightsavers, Orbis, and ODOX. He runs a distinctive advanced vitreoretinal surgical program known as the World of DKS, which is really quite famous at the Choitram Nethralaya. and imparts diagnostic and surgical retinal skills to young ophthalmologists. And his special interests today are expanding the horizon of retinal imaging, innovating retinal surgical techniques, and developing telemedicine tagged with artificial intelligence. With that, I'd like to invite Dr. Dhaivat Shah, sir, to give us his thoughts on the recent advances in this topic.
Hi, Anu. And it's always a pleasure seeing your beautiful smile, whether it's live or whether it's on the Zoom channel. So it's a wonderful study. I think this is what we see in clinical practice also. It's quite relevant, as my colleague just spoke about. Very, very practical. There are two aspects which I wanted to actually discuss. First is the aspects of injections. So they have mentioned sometimes they have used steroids also. They have used Ozurdex as a part of the study, and sometimes they have used anti-VEGF injections. And have they mentioned anywhere, Akash, in the study which anti-VEGF they have used?
No, sir, they have not
not
described it specifically.
Okay. So I think these are highly confounding variables, because the type of anti-VEGF, as we routinely know now, there is a spectrum of anti-VEGF, and there are some anti-VEGFs that respond drastically, significantly to the macular edema. So, I mean, looking at the newer aspects, I think this is something to consider. So, for example, when you are giving, brolucizumab in a fresh case, I have seen that the rate of reduction of macular edema is so fast. Since it's a smaller molecule, the penetration is better. But sometimes these patients, unfortunately, land up with foveal thinning. So it's very important what kind of anti-VEGF we are using in these patients as compared to the other ones. Sometimes bevacizumab might not act in one kind of edema. So I think this factor has to be, a little precariously considered in a study like this. The role of which specific anti-VEGF is what. Apart from that, I think the findings are quite justified. Again, my colleague just spoke about, Dr. Rohit. Systemic control is very important. Small things like anemia or associated hypertension or patient on long-standing insulin therapy, all these small things, they play a long role in private practice, especially.
Thank you so much, sir.
Thank you.
It's really nice to hear from you and picking up that salient point, which I think went missed throughout the initial portions of the webinar.
Yeah, absolutely.
With that, I would introduce and invite Dr. Shashwanti Mohan to give her final thoughts on the entire topic. Dr. Shashwanti Mohan is a specialist ophthalmologist in Retina at the Medcare Eye Center in Dubai, and she's also the Education and Research Associate working remotely at the Rajan Eye Care Center in Chennai. She's a gold medalist in DNB ophthalmology from the LB Prasad Eye Institute, and after that, she completed her fellowship in Retina from Shankar Nethralaya, Chennai. And driven by her passion for education and research, she has numerous ophthalmological educational sites, one of which is really famous, which is called Ophthalmobites, and a recent one which is gaining a lot of traction on social media called Retina 101 by SM. She has a keen interest in research and has published numerous articles. She's also a fellow of the International Council of Ophthalmologists and a member of the Royal College of Surgeons and a prolific lecturer at the cyber site by Orbis International. With that, Shashwanti, I'd send over the mic to you. Dr. Aniruddha sir has just texted me and told me that he'll be joining in 5-10 minutes. So till then, I'll keep the mic with you.
Okay, can you hear me?
Yes.
Thank you so much, Akash, for a wonderful presentation. It was very easy to mentor him, I think, this 1 month because he was so fast with the changes and he was always updated. So very easy mentorship for me, actually. Maybe I only made extra changes unnecessarily, but he very, very good job. He had a very clear understanding of it from the beginning and very minor changes we made throughout the entire thing. So I think almost it's been very well covered by our other panelists. Every aspect of this paper has been very well covered. Can I just share my slide, just 1 or 2 slides?
You can.
Can you see this?
Yes.
So I just wanted to see, discuss how to look at the results. We've already discussed many of this. I'm just going to recap that everybody's mentioned. Actually, Daivat also just mentioned what I was exactly going to say. Daivat, thank you. And Dr. Rohit also mentioned the same thing. So limitations, we have to look, it's a small sample size. Obviously, with the number of DMEs, we probably see in India, it's a very, very small sample size for us to even extrapolate it to our country also. And obviously, the retrospective design, which comes with a lot of bias, which they've also mentioned in the paper. And they also didn't have a control group. When I mean control group, we don't know whether any patient, there have been studies where they've seen that there's retinal thinning and inner retinal thinning, even in patients, diabetic patients and diabetic retinopathy patients without diabetic macular edema. So that could have been a possible control group, or just like Daivat said, maybe based on the kind of injections that was given, that could have been a subgroup analysis, control group, but they had not given us many details on that. And very important is confounding factors, which even Akash had mentioned in his MARI analysis. The systemic status and other diseases were not mentioned. Any kind of drugs that they've used, we know the lipid-lowering drugs can also affect the retinal thickening. So all these have not been clearly looked at when they've seen the paper, when they've done the paper. And another important thing is follow-ups weren't regular or similar for all patients. So Dr. Rohit really very clearly pointed out that the follow-ups could have been very varied. So I think that was one of the main disadvantages for sure. Another thing is the lack of correlation with visual acuity. So if you see that the visual acuities actually remain stable, the p-value was not significant, I think, across the visits. So has this had any effect, the retinal thinning and the thickening, has it had any effect on the visual acuity or not? It's not clear from the data that they've given, because the data on visual acuity is very less. They've only given one line on it, and the p-value is very insignificant, and a very similar pre and post visual acuity has been noted for these patients. Again, very important, no clear data on the anti-VEGFs or the switch between the injections. That's also very important because we don't know and Dr. Daivat said very importantly, the type of anti-VEGF also was not clearly mentioned, and that's also very important. And this Akash already mentioned, there was limited generalizability. We cannot extrapolate this to populations that have different demographic characteristics, treatment protocols, or disease severity. However, there are good strengths to this. It's a real world scenario. We are seeing patients who are being treated in PRN basis in a real world scenario. And it has a good enough follow-up. 3 years is a very good follow-up with a longitudinal design. And they've done an objective measurement with OCT. And also what I liked about the paper is that they looked at the inner and outer retinal thinning in the different foveal areas versus just the retinal thinning overall. So that's also was mentioned by Dr. Rohit. So I think that's also a very good part of the paper that they've looked at. And also using the different phenotypes, although the numbers were not very good for each phenotype. For example, the SND was only 13 eyes, I think. And to talk about recurrences in SND in those small, very, very small cohort of 13 eyes, and then concluding that they probably read to outer retinal thinning is a difficult thing to think about because the sample size is very less. So I just wanted to point out the limitations and strengths. Everybody's already covered it. But another very important thing is to look at the clinical significance, because we are treating patients, we're not treating OCTs. So obviously what this paper does bring into light is that treatment optimization is very important based on if in fact there is retinal thinning based on the type of anti-VEGF they're using or the type of steroids they're using, then we have to change the treatment accordingly. And the patient monitor, and for prognosis, it's very important to tell the patient that if they don't, for example, if SND is having a lot of recurrences and these patients do end up with outer retinal thinning, it's very important to explain to the patient as well that they need to follow up a lot more frequently in cases of SND, at least compared to others. And obviously future research and targeted therapies to prevent retinal thinning, because whatever it is, we're not treating OCTs, and finally we're treating patients, and the vision is important. Even if we get perfectly no fluid on OCTs, there's no point if the patient's vision is not improved. So I think this is what I wanted to talk about. And I think Dr. Aniruddha is there probably to talk about his side.
Great. Thank you so much, ma'am. Thank you for summarizing everything for us. Aniruddha sir, are you there?
Hi, can you hear me?
Yeah, yes, sir, I can hear you. I will just introduce you for 1 nanosecond, and then we can, I'll give you the mic after that. Dr. Aniruddha Agarwal is currently working as a staff physician at the Cleveland Clinic. He was a faculty at the PGIME at Chandigarh before this, and he had completed his clinical research fellowship from the Stanley Turson Eye Institute in Omaha, Nebraska, following which he completed a surgical vitreoretinal fellowship from PGIME at Chandigarh. He is also the recipient of the Kataria Memorial Gold Medal from the Prime Minister in 2014 and has authored numerous publications and book chapters with his interests including but not limited to ocular imaging, retinal diseases, and uveitis. With that, sir, I hand over the mic to you.
Thank you, Anujit, for the introduction. And I'm sorry I was not able to speak earlier. I think first hats off to all the team of YOSI for this. And it was a great discussion, very well worked out paper. I think a lot of critical analysis has already been done. And Shashwati did a great job in picking out subtle things, that we must learn from these papers in terms of limitations and applications. So I think what is important for us to understand is that in clinical practice, that we have started to pay less and less attention to really OCT-based biomarkers in the recent times. I think we have to understand that we have several options now for treatments. We have so many anti-VEGFs available. We have at least 2 types of corticosteroids that we can use, Iluvien as well as Ozurdex. Ultimately, it has to be not just the macular area that we are treating. We are treating, of course, the periphery and the mid-periphery as well. So I think a holistic approach is very important. And for the young researchers who are interested in imaging analysis, I think quantification has become really important. So while we talk about thinning and we talk about various layers, I think it's important to focus on function, which I think Shashwanti very elegantly pointed out, that this manuscript did not show correlation with visual acuity. And so ultimately, I think the goal is that you must focus on the patient's visual outcome, not just the OCT. And you may have situations where the OCT is quite poor and the clinical outcomes are actually not so bad. And in these situations, the patients can end up doing very well. So assessment of biomarker has to be a dynamic process. And I think it has to be done almost at every visit. And in your clinical practice, if you're busy with lots of patients, I think basic biomarkers are more than enough to be able to have a good clinical judgment whether which agent you want to use in your practice. So I think with this, if any questions, etc., we can all discuss.
Thank you so much, sir. Any concluding remarks from the panelists?
Hi, Anujit. Daivat here.
Yes.
So, Anujit, I have one question for you and for the panelist. A treatment-naive patient, diabetic 40-year-old, macular edema, you can say with a little bit of neurosensory detachment. What would be your choice of anti-VEGF today?
At this point of time, I think we are usually going ahead with ranibizumab. If considering the patient's visual acuity as well as his financial constraints, I think that in clinical practice holds quite a bit of importance.
All right. So let's take the financial part out. The patient is rich. He's from the Ambani family. So finance is not a problem. The visual acuity is, you could say, 618, 624. And he has been a diabetic since the past 4 or 5 years. The HbA1c, let's say, is 7.8.
Mm-hmm.
And of course, it's a moderate NPDR. There is no PDR component. So laser does not have a role here. So would you want to change the anti-VEGF or would you still want to stick on to ranibizumab? I would love to have everybody's poll on this.
If I may, my first line has now changed to Eylea. So I use Eylea as first line.
I was going to say Eylea also.
Yeah, maybe it's a different region of geographic region of practice.
That's right.
But of course, I think
the Middle East
ultimately
is supporting Eylea.
No, actually, even cost-wise, if you see, it has a good patient support program. So I feel economy-wise, it amounts to almost the same thing.
Absolutely. So that is actually what I was trying to point out. The changed, that there's a change in the trend now. And actually, Eylea is, personally speaking, I also tend to give Eylea if finance is not a problem. And as Anirudh pointed out, I mean, they have the Eylea, for the Indian population, they have the 2+3 program. So yes, of course, at the end of 3, 4, 5 injection, the cost turns out to be nearly the same. Last question for especially the Indian ophthalmologist. I would love to have Rohit's view on this. Any remark on the biosimilars?
So, Devat, again, my first choice would be Zaltrap instead of Eylea because it reduces the cost significantly. And I don't use biosimilars. I believe Aflibercept works much better than the current biosimilars we have in the Indian market. And, Aflibercept is also much cheaper than the biosimilars which we get.
True. So still we are sticking to Aflibercept instead of going ahead with the ranibizumab. Yes. Okay. Lovely. Thank you.
Usually I use biosimilars, usually ranibizumab biosimilars initially as this thing. Nowadays I stopped using Lucentis or Accentrix because of this thing. I usually go with biosimilars like ranibizumab or Osiva or directly shift to Eylea.
So is cost the confounding factor here, or are you getting better results or equivalent results?
To be frank, most of the patients are, will be bevacizumab than the ranibizumab and all in Indian scenario. Okay, where most patients the cost is the issue. Definitely, if cost is not a pattern, nowadays Pegenex is also, I think DME it is approval has come, so we can try that also. But if given an option and the finance is not an issue, Eylea will be definitely first line. Else I use ranibizumab as the first line.
So is anybody from the panel using Pegenex as a first line, brolucizumab as a first line?
I'm using brolucizumab and DME. Yeah.
As a first line therapy for treatment.
Yeah, I have used it first line. Yeah, I have used it.
Okay. And how are the results? As good as Eylea?
It's much safer. It's much safer. Yeah, it's like Eylea, and it's much safer compared to AMD. If you look at the Kite and Crestel, there's hardly any side effect with brolucizumab in terms of inflammation in diabetic eyes.
True. And do you feel the number of injections required are less as compared to Aflibercept?
In 1 year, probably 1 or 2 injections less, but not drastically different. Even faricimab, we have faricimab here, Vabysmo, who they claim to be quite, long lasting, but ultimately I think it's probably 2 weeks more than Eylea only. So all of these are almost the same.
Okay. And are they promoting faricimab for treatment naive patients? Because as far as I've read, they are using it for residual DMEs or refractory DMEs.
Faricimab is first line for even
first
naive
line
patients.
therapy. Yes. Okay.
Even brolucizumab.
Okay. And do you use loading 3 for brolucizumab too, or do you week 6 week or 9 week interval?
Yeah, so I think it's we are following the trial protocol for faricimab now, 6 weeks loading, and then it's a complicated protocol. So ultimately, it depends on the patient's follow up.
Sure. Lovely. Thank you.
Excellent discussion. If there's anyone from the audience with any questions, in the meanwhile, I'll just go ahead with concluding the session for today. I would like to thank everyone who was a part of this session, both in the audience as well as the panel members. I would start by presenting a certificate of appreciation to Dr. Akash Chaudhary for being the speaker for the month of May at the YOSI Journal Club, Dr. Shashwanti Mohan for being the monthly mentor for the month of May for the YOSI Journal Club, as well as to Dr. Sharath Hegde for being the research expert, and to our prolific panel members, Dr. Aniruddha Agarwal, Dr. Rohit Modi, as well as Dr. Dhaivat Shah for taking time out and sharing their insights, not only on the article, but also relevant clinical practice points, which are the actual take-home message from sessions like this. With that, I'd like to invite everyone for the next YOSI Journal Club, which is in the month of June, which is going to follow cataract surgery. Once again, if you've been part of the journal club and you would like to be a part in presenting or working as a panel member or as a research expert, please send in your requests at this mail. Please take a screenshot. And with that, we conclude the session. If everyone can just switch on their videos for a screen